Hello and welcome to the topic Arterial Ulcers in the Dermatology module. By the end of this topic, you should be able to define arterial ulcer, explain the pathophysiology of an arterial ulcer, outline the causes and classifications of an arterial ulcer, describe the clinical manifestations, outline the investigations done, discuss the principles of management, and discuss the complications and prognosis of this condition. Let's get started. Ulcer is a break in the skin or mucous membrane with loss of surface tissue, disintegration, and necrosis of epithelial tissue. An arterial ulcer is a result of poor delivery of nutrient-rich blood or poor perfusion to the lower extremities. The word ulcer comes from the Greek term alkos, which means a wound, sore, or break in the skin. Now this picture shows the blood supply of the lower extremities. The main artery of the lower limb is the femoral artery. It is a continuation of the external iliac artery, the terminal branch of the abdominal aorta. The external iliac becomes the femoral artery when it crosses under the inguinal ligament and enters the femoral triangle. In the femoral triangle, the profunda femoris artery arises from the posterolateral aspect of the femoral artery. It travels posteriorly and distally, giving off perforating branches which are the lateral femoral circumflex artery and medial femoral circumflex artery. After exiting the femoral triangle, the femoral artery continues down the adductor canal, exiting through the adductor hiatus, and enters the posterior compartment of the thigh. It is now known as the popliteal artery. The popliteal artery descends down the posterior thigh. At the lower border of the popliteus, the popliteal artery terminates by dividing into the anterior tibial artery and the tibio-peroneal or tibio-fibular trunk. Anterior tibial artery passes anteriorly between the tibia and fibula through a gap in the interosseous membrane. It then moves inferiorly down the leg. It runs down the entire length of the leg and into the foot, where it becomes the dorsalis pedis artery. Tibio-peroneal trunk then bifurcates into the posterior tibial and fibular arteries. Dorsalis pedis and posterior tibial arteries supply the foot. The underlying risk factors such as smoking, diabetes mellitus, hypertension, and hyperlipidemia contribute to atherosclerosis or arteriosclerosis. This leads to arterial narrowing or obstruction and reduces the blood flow to the lower limbs. Eventually, tissues at the lower extremities receive not enough nutrients and blood, hence ischemia, necrosis, and ulceration may occur. The causes of arterial ulcers include peripheral vascular disease, chronic vascular insufficiency, vasculitis, diabetes mellitus, renal failure, high blood pressure, hardening of the arteries or arteriosclerosis, thickening of the arteries due to the buildup of fatty materials, trauma, limited joint mobility, and increased age. Now, arterial ulcers can be classified according to the Rutherford classification. Grade 0 or Category 0 indicates asymptomatic ulcer. Grade 1 can be divided into Category 1, 2, and 3, which indicates mild, moderate, or severe claudication respectively. Ischemic rest pain is classified in Grade 2 or Category 4, while Grade 3 can be classified into Category 5 or 6, in which minor tissue loss for Category 5 and major tissue loss for Category 6. Now let's discuss the clinical manifestations of an arterial ulcer. Patients usually complain of painful ulcer with skin changes, lower limb pain after walking for a fixed distance or even at rest. If there is infection, there might be fever present as well. As we are examining the ulcer, we may notice an ulcer with punched out appearance, round in shape, and well-defined margins. The ulcers are usually found between or on the tips of the toes, on the heels, and on the outer ankle where there is pressure from walking or the footwear. The ulcer is usually deep, often extending down to the underlying tendons, and will frequently display no signs of new tissue growth. Base of the wound typically does not bleed, and it's yellow, brown, grey, or black in color. The lower limbs of the patient are usually cold to touch. The lower limb pulses are faint, and there will usually be no distinguishable pulses otherwise. The skin and nails appear atrophic. There may be hair loss on the affected extremity. The lower limbs appear to be shiny, thin, dry, and taut appearance. Base color of the extremity may turn red when dangled and pale when elevated, and there's delayed capillary return in the affected extremity. Physicians should look for systemic signs such as hypertension and signs of hyperlipidemia such as xanthelasma, tendon xanthoma, and corneal ulcers. This image depicts a typical arterial ulcer. The arterial ulcer is typically well defined, punched out, and it's a painful ulcer. Now let's go through the investigations. Imaging study of the lower limb blood supply is the most important test. Femoral runoff study angiography is the study of choice. It reveals the filling of the vessels, leg vessels down to the ankle. The plantar arch also may be visualized if the location of the wound is distal enough to warrant it. An MRA can visualize both runoff vessels and arterial stenosis. Transcutaneous oxygen monitoring is a non-invasive method of measuring the oxygen level of the tissue below the skin. Records of the oxygen delivery capacity of the vascular system is then taken. Toe brachial index can be done when the ankle brachial index is abnormally high due to plug or calcification of the arteries in the leg, and this is caused by atherosclerosis. Burgess test is the assessment of arterial insufficiency. Angle between the limb at which PLAB begins and the horizontal plane is known as the Burgess angle. When angle is less than 30 degrees, this indicates severe arterial occlusion. Now let's discuss the management. The most essential management of arterial ulcers modifying the contributing factors. Blood pressure, cholesterol, triglyceride, and glucose levels must be managed to prevent the worsening of an arterial ulcer. Smoking cessation is another important strategy. Antibiotics is only indicated if the ulcer is infected. So the first choice of antibiotics is oral flucloxacillin. This can be given at 500 milligrams to 1 gram 4 times a day for 7 days. An alternative choice of antibiotics would be, for those with penicillin allergies, would be doxycycline or clarithromycin or erythromycin for pregnant women. Second-line oral antibiotics include coamoxiclave or Augmentin, or cotrimoxazole or Bactrim if penicillin allergy. If patient is severely unwell, consider intravenous flucloxacillin with or without gentamicin and or metronidazole, which can be considered. Coamoxiclave with or without gentamicin or cotrimoxazole with or without gentamicin and or metronidazole are the alternative first-line intravenous antibiotics therapy. Second choice antibiotics for severely unwell patients are piperacillin tazobactam with or without metronidazole. If methicillin-resistant Staphylococcus aureus or MRSA infection is suspected or confirmed, vancomycin should be added to the regimen. Surgical therapy is to increase the circulation of lower extremities. Revascularization such as angioplasty, stenting, bypass, and grafting can be considered to restore the blood flow. When revascularization cannot be done in the patient, amputation is the alternative option. Patients too should take care of their arterial ulcers carefully to prevent infection. The wound must be kept dry. Cadoxomer iodine around the wound margins may draw exudates and particulate matter from the wound. Then, when moist, releases iodine, serving the dual purpose of cleansing the wound and fighting bacteria at the wound site. Complications of arterial ulcers are infections, tissue necrosis, and this may then require amputation. Aggressive conservative wound care and near normal ankle brachial index provide good prognosis. However, ankle brachial index less than 0.5 and peripheral arterial disease show poorer prognosis. In summary, arterial ulcers are breaks in the skin or mucous membrane caused by poor perfusion. The underlying risk factors causing atherosclerosis or arteriosclerosis leading to reduced blood flow to the lower limbs eventually leads to arterial ulcers. The causes of arterial ulcers include peripheral vascular disease, chronic vascular insufficiency, painful punched out well-defined ulcer, claudication and rest pain. The investigations of this ulcer include femoral runoff angiography, magnetic resonance angiography, transcutaneous oxygen measurement, and toe brachial index. Most essential management of arterial ulcer is modifying the contributing factors. Infected arterial ulcer should be treated with antibiotics, and surgery can help to increase circulation to the area or amputation. We have come to the end of this topic. Thank you.